Welcome back. Today we'll be discussing how to be an EMT. I could also entitle this, what are your next steps after certification? I'm just going to cover some of the things to keep in mind. How do we actually take the classroom and put it into the field, and then how to do things like recertify your card and all that. I will put the caveat, if you're not listening in New York State, a lot of this information might be different. I am a New York State certified provider. I'm used to the New York State rules and regulations, so that's what I'm going to be focusing on. So, one of the first things, and I'm not trying to say this to be demeaning or anything, but in class, you don't really learn that much. You learn some of the science behind a lot of this stuff, but you don't get a great grasp of how to actually do this job. So keep that in mind when you're going and actually doing this in the real field. You don't know that much. So keep on learning, learn from every single call, talk to your coworkers, talk to people that are in charge of you, talk to your training directors. Try to learn something from every call that you go on. And also try not to have that big of a head. You know, an EMT class, mine is about 155 hours total. Sometimes doctors make some questionable decisions. Doctors, they go through 4 years of med school and 4 years of residency before they can practice independently. That is a lot more time than you have spent training. So they might make some questionable things, but they also know a whole lot more science than you. So they might have their own rationale for making their own decisions. So just keep that in mind. You are a very entry-level provider. Never stop learning. Now, with all that being said, don't just kind of pass off your accomplishments. You did get certified as an EMT. You made it through the end of class. You hopefully will get your card in a little bit. So that's something to be proud of. Don't let people put you down for wanting to do this job and being excited about this job. When I first started, I lived, breathed, ate EMS. Um, yeah, I could not get enough of it. And there are a lot of people out here who have been doing this job for a very long time, and they'll make fun of you for being excited. Don't let people take your excitement away from you. As soon as you lose your love for the job, your passion for the job, that's the first step to getting burnt out and leaving this profession altogether. So keep your excitement about you. Be proud of what you do. Another big problem in this field is there's a lot of people who are, what we call salty. Uh, they will have a lot of negative effects on you. You might want to be like one of the cool guys, one of the guys who don't care about anything, one of the guys who've been around forever. A lot of those providers are not good. They've lost their empathy, they've lost their ability to care for people. They're just doing the job to get a paycheck. And there's a nice balance between having experience and still having the excitement to treat patients and the empathy that goes along with that. Remember, we're taking care of humans. This is a human to human interaction. It's not just a hunk of meat sitting in front of you that you have to do the job to. One of the greatest pleasures I have is I get to see third and fourth year medical students, and I get to teach them some ACLS classes, which is dealing with more advanced cardiac arrest stuff. But it's so much fun to teach them because they haven't seen many patients yet. They're so excited to actually help people. Keep that in mind. You are here to help people. You should be excited about seeing people. Don't let people take that away from you. All that being said, yes, being excited is great, but remember, there are other things to life besides doing this. Don't let this consume you. That is the big key to not getting burnt out. You have to have other parts of your life that you enjoy, other parts that you do. It is okay to turn that pager off. It's okay to not pick up the overtime shift. Make sure that you have something that is completely separate from this and that you're not doing with your friends that you made in fire or EMS. Have outside friends, ones that are not going to talk about the job all day long, and do something fun with them. For example, I am a relatively avid golfer, or I really love going out on the lake during the summer. I usually do this with people who don't work fire EMS because I don't want to be talking about fire EMS when I'm not on duty. That's one big part of my work-life separation that has kept me doing this for the 10 plus years that I've been doing this job. All right, so you got certified. What now? Uh, Keep in mind, in New York State, this is a certification. The vast majority of the country, EMS is a certification. And in order to practice medicine, you need to have a license, which means we practice under a licensed physician. And something that we talked about day one is who do we practice under? We always practice under a medical doctor, and we practice under their license. So keep that in mind. You cannot just go out and be like, all right, I'm an EMT. Let's start doing things to people. You are an EMT only when you are practicing under someone's medical license. Besides that, you cannot practice medicine. You do not have a license to practice in the state. Most agencies, at least any agency worth your time, should have what's called a clearing process. When you are clearing, you are going to be riding with other EMTs or paramedics, and your job or their job is to make sure that you actually know how to do this. So that's when your real training actually begins. It's can we take this person from the classroom setting and put them into an actual clinical setting and have them independently practice. You cannot independently practice until you have been cleared. When you are cleared, that is the medical director's way of saying, yes, this person can practice under my license. Until you've been cleared, the medical director does not allow you to practice independently. That being said, even when you're being supervised, if you do something grossly negligent, it is on you. You are still practicing as an EMT, just not an independent EMT. So make sure that the point is to learn and to be supervised. Make sure you don't do anything grossly negligent. You should have learned during class how to not be grossly negligent. If you make minor mistakes here and there, okay, that's what clearing is for. That's what doing this part is for. But don't do something grossly negligent during that time. You will be held liable for that. So in New York State, there are several different regions that we practice under. I happen to be located in the Central New York EMS region. Most regions are a couple counties big, so if you move or you get another job somewhere else, you do have to see if you're in the same region. When you practice under the medical director and you practice under your region. So they are a supervisory agency for you. You do have to get permission from the region to practice. So if you're in the CNY EMS region, you have to go online and register with them. Most regions require protocol tests. They might put out some other regional trainings as things evolve in EMS, and that's the responsibility of the region. The region will say yes or no, you can practice inside this region or not. So the state can say yes, you can practice inside the state. The region then says you can practice inside this region. Then your agency says you can practice at this agency. So there's a lot of steps to actually practicing independently. Most regions require continuing medical education validation. For example, in the Central New York EMS region, they require skills every 12 months at the basic level. At the paramedic level, they require 24 hours of education and skills every 6 months. So it does change with your education level. So for this region in December, you have to sit down with a regionally approved evaluator and go over some specific skills just to make sure that you are up to par for practicing alone. So they're usually relatively simple, like giving epinephrine or giving albuterol. Just making sure that if you haven't practiced all year, that you still haven't lost those skills. When you do sign on with the region, you usually have to also align with an agency. So it's kind of a twofold process of you get aligned with an agency and they say, okay, align with our region. You do both online at the same time, and then you're good to go. All right, so let's talk about driving. I know we talked about driving a little bit in EMS operations, but driving is a big, big, big part of an EMT's job. There's a reason why a lot of people in the public call us ambulance drivers. It's, someone has to drive, and a lot of times if you're working EMT paramedic, half the time you're going to be driving. So some general principles to think about. Smooth is a whole lot better than fast. Especially if someone is working in the back, I'd much rather be a smooth transport than a quick transport. We are trained to take care of these patients. Yes, is it nice to get them to the hospital a little bit quicker? Yes, but I need to be able to work on the patient during that time that we're transporting. So please remember to try to keep things smooth. Smooth versus fast will also help keep you away from accidents. If you crash your ambulance on the way to a call, you're not going to be able to help anyone. One kind of common saying in EMS, and it's overused, so it's probably not proper for me to say, but it's that this is not your emergency. You shouldn't be acting like this is your emergency. You shouldn't be freaking out. You shouldn't be really, really rushing, because when you rush and you freak out, you can't think straight. You start to make mistakes. So keep that in mind. This is not your emergency. You're responding to someone else's emergency. So we do want to be expeditious, but you can't be running too fast in your head or running too fast physically, because if you get too amped up, you're not going to think straight. You're going to start making mistakes. Another big thing is ambulances are different vehicles. If you are driving an ambulance, it takes a little bit of practice to handle, and especially to back up. You don't have a big mirror or big window in your rear where you can look out when you're backing up. You have to back up using just your mirrors. So practice backing into spots. Backing is a huge part of operating an ambulance. One thing that you'll see a lot of people doing is a lot of people in fire and EMS will always back up their personal vehicles when they park somewhere. That is a good way to practice the principles of backing up. So when you're just driving with your normal vehicle and you come to a parking spot, back into it and use your mirrors instead of looking out the back or even using your rear view mirror. Use those side view mirrors and get used to doing it that way. If you get used to doing it in a smaller vehicle, it'll be a little bit easier in a larger vehicle, especially a larger vehicle in a chaotic scene where there might not be much room. All right, so everyone's favorite, working with paramedics. So ALS does cover advanced EMTs and paramedics. They are a higher level of care than you. So when it comes to call management, it is their decision over your decision. If they are making a poor decision that you disagree with, it's ultimately their head. Um, if they're doing something grossly negligent and you don't say don't do this, you might be held a little bit responsible. But for the most part, it's on them. It comes with the nature of being an advanced provider, is that you are responsible for pretty much everything that happens on that ambulance. Again, if you see something that you know is going to severely harm the patient that they're doing, especially if it's a BLS skill that's going to harm the patient, maybe say something. um, they aren't gods. They can do something wrong. So that's part of your job, is to, if you see something, say something. But if they really persist that, no, this is what I'm going to do, it is their call. If ALS tells you to do something wrong, and you know it's something wrong, you can refuse to do it. If they tell you to put an OPA in a conscious patient that has a gag reflex, that's gross negligence. Don't do that. There are not many instances where they will tell you to do something. I can probably count on one hand in my 12 years of doing this job that I've even heard of someone doing that, but it might happen. So keep that in mind. You are trained to be a fully functioning EMT. If you're told to do something that is wrong and you know it's wrong, you can refuse to do it. Try to keep it minimal on scene. Just say, I don't feel comfortable doing this. If you need to do this, then you can do it. And then have the discussion after the call as to why you did not want to do it or why you thought it was grossly wrong. And hopefully that will be a learning experience where they can maybe tell you their rationale behind something, and they may have been right. You could be wrong too. So you can use it as a learning experience versus an arguing experience. Ultimately, the ALS provider does make the ALS-BLS decision for the patient. So they will decide if the patient's being transported at the BLS level or the ALS level. You might disagree with that decision. If they're trying to give you the patient and you do not feel comfortable transporting that patient at the BLS level, then you should let them know that. They might take the patient at the BLS level, but if you don't feel comfortable with it, you need to let them know that. Say, I really think this exceeds my scope of care. I don't feel comfortable taking care of them by myself. And then give it to the paramedic. The paramedic or advanced EMT may BLS it themselves because they have some more education than you do. They might see other things. And again, if that occurs, talk to them after the call. Be like, okay, why did you see this as a BLS patient versus an ALS patient? Try to figure out what they were thinking about. Again, it's not a yelling time. It's more of a let's figure things out and learn things together time. So if you are on an ambulance, the chance of you getting paired with the ALS partner is high. And I won't say unfortunately, because it can be fortunate, but every ALS provider does things a little differently. They have their own preferences on how they like to do things. For example, I am a very independent ALS provider. When I first started doing EMS, I was brought up in an environment where my partner may not have been a certified EMT, so I may not have had any help whatsoever. So I learned how to do things almost entirely on my own. So if you're partnered with me, if I get a patient in the back of my ambulance, I don't need any help. I ask my partner to start transport. There are some providers who really would like help on a lot of calls, so you might load the patient in the ambulance and then they might ask you to set up their lock, put the patient on the monitor, get a full set of vitals, do part of the patient interview with them. They might spend an extra 20 minutes on scene with you in the back helping them. So everyone's a little different, and that does get a little frustrating at the EMT level because you have to adapt to how they want things run. So try not to get set in your own ways. Be adaptable to how the ALS provider wants things done. Ultimately, on an ALS patient, you are there to assist them. Just like on a BLS patient, they're there to assist you. So you have to be a little bit adaptable to what they would like. One of the biggest things you can do, especially if you are being partnered with someone, so you're not just seeing them when they first show up on a call with you, is ask them how they want things done, especially if you're going to be partnered with them routinely. My most recent partner, when she came on to be my partner, first thing that she asked is, how do you do things? How do you want things set up? And I went through it with her before we went on our first call. So that's something that you can do. Um, I've said this a few times, but if something doesn't make sense to you on a call that you witness, ask them, and preferably after the call, but ask them, I saw this, what happened? Most people are more than happy to explain their decision making to you. So keep that in mind, is that we are always continually learning. You can learn from a lot of people out there. You might learn what to do, and you might learn some things not to do. If you see something that you think is wrong or that you don't like, then that will help mold you as a provider to be like, okay, I don't want to be like that, so how can I not be like that? Like if you see someone who is not empathetic at all, you can see, okay, they don't talk to their patients, they don't show any emotion, I don't want to be like that, and it'll help you change. So when you're assisting an ALS provider, there are some skills that you really should have locked down. Um, Class, we kind of touch on these things, but you should really go to your agencies and ask to go over these things. Get a paramedic that you trust or that you get along with and ask them to do this with you. And keep in mind, every paramedic sets things up a little differently. So if you have a routine partner, it's very appropriate to say, okay, how do you want your locks set up? How do you want your tubes set up? How do you want this stuff set up? But the skills that you really should have honed down, especially if you're working with ALS routinely, is how do you set up lock set, how you set up a ET tube, how you set up an IV bag, and then one thing that you should know if your agency is capable of it is how to put the patient on the monitor and doing and transmitting a 12 lead. Again, we kind of touch on it in class a little bit, but you really need to put your hands on this stuff and do it over and over and over again until it becomes muscle memory. Keep in mind, yeah, ALS stuff is fun to do, but BLS always comes before ALS. Yeah, if I'm intubating a patient, yeah, that's the fun thing to do. Yeah, woo. The most important thing to do is to bag that patient beforehand and bag them with an OPA and or NPA. So that's very critical. If you can't do good BLS, you can't advance to the ALS stuff. If you can't bag this patient, then they're going to die before I get a tube ready. So keep your BLS skills in mind. They are critical to patient survival. Yeah, they're not the fun, glory things to do, but they are the critical things to do to keep this patient alive. And again, some ALS riders might not want any help with their skills. Like I said earlier, I'm a relatively independent ALS provider. I like to set things up myself just because I then know exactly where everything is. If someone else sets something up for me, I might not know where the random item is when I need it. Like If I'm intubating a 10 cc syringe, if it's not attached the way I attach it, I might be looking around for that when I really should be focusing on keeping that tube stable. So I like to set things up myself just because I know where everything is, and I have no one to blame except myself if something goes wrong. All right, so next we'll talk about one of the harder decisions to make sometimes, and that's when to call for ALS. So it's something that you're going to kind of learn over time. There's a lot of things that might pop up that you'll be working with an ALS provider and they'll ALS something that you're like, oh, I thought that this would have been a BLS call all day. And that's another great time to learn. Ask, why did we ALS this patient? So I know for future reference things to look for to call for ALS. That's something that I learned a lot when I was a brand new BLS rider, where all the minute things that could mean something else is happening in the body. So some things that we look for. Epigastric pain in women. Generally, if it's upper abdominal pain in women over 45, that could be a symptom of an MI. And if it's pain below the navel in women under 45, that could be a sign of ectopic pregnancy. Both of those are at least warrant ALS assessment. Next is symptomatic hypertension. So when a patient is hypertensive, the first thing I ask is, do you have a history of this? If they have a history, it's a little less concerning usually, especially if they don't take their medications. But then the next question is, are you symptomatic of it? Do you have complaints associated with this? Some things that we look for are blurred vision, headaches are a huge one, ringing in the ears is another huge one. So it's things that having high blood pressure causes. And that usually indicates that the body is not used to the blood pressure being this high because it's reacting to it. You're seeing symptoms of it. So that usually should warrant some sort of cardiac evaluation. Lightheadedness and dizziness are other ones that can either be neurologic issues or cardiac issues, so it at least warrants an evaluation. Weakness and fatigue, especially in your geriatric patients. That's a large indication of myocardial infarction. Sometimes that's the only indication you might get, is just they feel really run down for some reason. That's not always the case. It could just be that they're dehydrated or that they just are feeling sick, or just, as I tell people, you got a bad case of old. But it's something that you should keep in the back of your mind of maybe this is something bigger that ALS needs to assess. Tachycardia, generally my number is around 135 and above is when I start to think, does this person need a cardiac evaluation? Below 135 is kind of normal compensation. Above 135 is when the body is really working hard because it's sensing a problem somewhere, especially if there's no explanation for it. If someone was just exercising, if I run a mile, my heart rate's going to be 180 for a couple minutes. So if there's an explanation, then okay. But if it's a patient at rest who has no other reason to be that high, it's worth an ALS evaluation. Any major trauma criteria should warrant an ALS evaluation. Any patient has a loss of consciousness. That's a big one. If something happened to where you lost consciousness, we need to make sure that it wasn't because of a heart dysrhythmia. So that's a big one, is any loss of consciousness, no matter how small. If you have someone who might need sedation, so anyone that you are actively restraining, not a bad idea to have ALS on the way, just in case if they need to be sedated. Because even if you restrain them, they might hurt themselves by fighting those restraints so hard. They might need sedation so that they don't injure themselves. Anyone who needs pain management, so someone who is truly in a lot of pain, which we talked about during this class, as to some of the things that go along with pain management. Again, never promise that a paramedic will give pain management. Just say, I'm going to have them evaluate you to see if you qualify. Pediatric fevers. ALS, at least in New York State, can give Tylenol for the fever, and they also should be there just in case if there's a febrile seizure. And then the obvious ones, your shortness of breath, your chest pains, your seizures, your unconscious people. These are the ones that are obvious beyond the scope of EMT. And just keep in mind that even though you call for ALS, that just means ALS needs to evaluate the patient. ALS might come and say, no, this is appropriate for BLS care. Yeah, that's all that calling for ALS does, is they are there to evaluate the patient at a little bit higher of an assessment level. They might say that the patient's fine for BLS care, or they might take this patient in at the ALS level. So don't be surprised if they say, no, this patient's okay for BLS care. Again, if you are uncomfortable transporting at the BLS level, make them know that. But these things just mean we need a deeper look into this patient. I need someone who has a little bit more tools, a little bit more expertise to assess this patient for me. All right, everyone's favorite thing, documentation. This is arguably one of the biggest things that is going to make other people think that you're a good provider or not, is if you can document well. So if you can be a very thorough and competent documenter, you're going to have an easy time clearing at agencies. That's usually the one thing that hangs a lot of people up with training, is they can't document things well. So keep in mind, every time that you get dispatched to a call, it needs a PCR filled out, even if it's an accidental dispatch. You know, that happens every now and then, where they accidentally dispatch your agency instead of the one that was supposed to go, and you get canceled immediately. You have to document that. Every run number that associated with your agency should have a PCR associated with it, even if it just says wrong dispatch, we were canceled. You know, it takes 5 seconds, but we need a PCR with every run number. I know I just said it, but if you don't document well, you can't prove that you provided good patient care. So keep that in mind, that this serves several purposes, but one of them is saying that, yes, I actually provided care competently. Every agency has a different charting system. That's why I didn't spend too much time in class going over specific documentation things, because I can teach you generalized documentation methods, but it's going to be specific to your agency's charting system. So sit down and learn that with someone. Have someone go over that with you. Then one of the biggest things that helped me when I was learning how to chart was I read everyone's chart on every single call I went on. I probably read 200 charts before I wrote my first chart myself. Granted, I wrote a lot before I got certified as an EMT, so that's where a lot of that experience came in. But I read so many charts that I was able to pick and choose those parts of the charts from people that I liked. So one person I liked how they wrote their history of present illness. One person I liked how they wrote their pertinent negatives. One person I liked how they wrote their termination of care note. And one person I liked how they wrote their scene description. So I just picked and chose the things that I liked from people's charting, and that's how I developed my own personal style of charting. So there is no one right way, one wrong way to chart as a whole. Everyone has their own style. As long as you have the required information, that's really what matters. So some things that you should have in your documentation. Again, you can have your own style, but there are certain components that you need. So most charts have two separate components to them. They have the check boxes, which help with like state reporting things and doing metadata, and they also have written areas. Your written area is kind of the meat and potatoes of your chart. There are three big things that you should include in your written section. Most people call this a narrative. So the first thing is called your scene description. So that should be everything that you saw from when you arrived on scene to when you made patient contact. That is your scene description. So for example, I would say arrived on scene to be met outside by the patient's daughter, who led us into the living room to where we found the patient sitting on a chair. You should also put your general impression there. So the patient was found conscious, alert, and oriented to person, place, time, and events, and appeared to be in no obvious distress. So that's my general impression, was there's no obvious thing going wrong that I saw them. So right there is my scene description. Next, you should put why we were there in your assessment. So that's called your history of present illness and your patient assessment. So that's where we can say everything that the patient told us. So we talked about, we got there, we saw the patient, we asked what's going on, this is what they told us. So the patient reports that they've been having chest pain. The chest pain was rated as an 8 out of 10 throbbing sensation in the middle of their chest. The pain radiates to their left jaw. It started 2 hours ago when they were watching TV. Nothing's made it better, nothing has made it worse. They've never felt this type of pain before. They are also having mild shortness of breath with this. The patient's lung sounds were clear on assessment. The patient reports that the area is not tender on palpation, and that it doesn't increase when they move or when they take a deep breath. Right there is a relatively thorough history of present illness. It's everything that they told us, and just running through your OPQ or STI and your sample questions and putting it in there. The next part is everything that you did, including movements of the patient. This is the active narrative of the part. So we said everything we saw before we got to the patient, we got to the patient, this is why they called us, and then this is what we did to them. So we could, and this should be time stamped, but we could put in that we arrived on scene, we gathered our history of present illness, because that takes a few minutes. We assessed vitals. We then put the patient on a stair chair and brought them to the stretcher. We lowered the patient on the stretcher, put them into the ambulance. We began transport to this hospital at the ALS or BLS level, which for you at the EMT level should always be the BLS level if you're writing this chart. You can say I administered 324 milligrams of aspirin and say why you did it, so it's for the chest pain, and say if the patient improved or not. I then did a 12 lead and transmitted it to the hospital. We then arrived at the hospital, we unloaded the patient, we brought them to this room, I gave my verbal report to this nurse, and patient care was transferred to this hospital. Right there is a decent narrative. Just describe everything that you did from patient contact to terminating patient care. That way, when someone reads your chart, they have an idea of what you saw when you got there, why you were there, and then what you did for the patient. All right, time to talk about everyone's favorite part of this job, billing. If you work at an ambulance agency that bills, you need to have patients sign a HIPAA release. If they don't sign a HIPAA release, then you cannot send the patient's information to their health insurance provider. You're then going to have to bill the patient directly, and then they're going to have to submit it to their insurance, get reimbursement, and send it to your agency. It's a huge headache for the patient, and it delays getting payment for your agency. If your agency doesn't get paid, that means you don't get paid. So that's a very important part of our job, is to get a HIPAA release signature from every patient who is mentally competent to do so. You should have your own HIPAA training at every agency, and that will go over some of the competency things. So like if someone has altered mentation, they can't sign their own HIPAA form because they can't understand what they are doing. If they're unconscious, they obviously can't sign the form. If they have gross contamination to where they shouldn't be holding a pen because it's going to contaminate your pen or your charting software, then that's an acceptable reason not to get it at the time. If they're a minor, they can't sign. So there's a lot of stuff. Your agency should train you on that. Try to attempt to gather insurance information. Again, if we don't know what your insurance company is or your insurance information is, the bill goes straight to the patient. It creates a lot more steps and a lot more headache for everyone. Even if you're with the fire department, that is a great thing to do before the ambulance gets there, is just say, hey, do you have your insurance card with you? Or what's your insurance company? Just something that will help the ambulance gather that information later, because it's something that they need. And a lot of people forget when they're actively providing patient care to gather that insurance information. If you've left the house and the patient doesn't know their insurance information, you might not be able to gather that information at all. And again, it delays things. If you are on a motor vehicle accident, many people or many agencies require a separate signature because motor vehicle accidents are covered by car insurance. They pay for the medical bills instead of health insurance. So you need a separate signature to say, I release my information to my car insurance company so that they can provide payment. So you might need the HIPAA form and a release to send things to car insurance companies. Again, if we don't do this, it results in the patients getting billed directly, and it results in a lot more headache for everyone involved, and your agency might not get paid for this contact. So going on, motor vehicle accidents, New York State is a no-fault MVA state, which means if you get in an accident, your insurance will cover your medical bills. So that's why every driver is required to have insurance. The insurance covers you and everyone that's in your vehicle, regardless of who is at fault for the accident. Most insurances will have a set time frame that the patient must be evaluated in. A lot of times it's between 24 and 48 hours. So let the patient know that if they don't go to the hospital because they don't feel like they have major injuries, let them know that if they feel anything to please get evaluated, because after a certain period of time, your car insurance might not cover and will go back to your health insurance, which might not be as good of coverage. In New York State, you can find car insurance via the license plate. So if you're in the fire department and the ambulance hasn't arrived yet, write down the license plate of the vehicle that the patient was in. And if we put that into our charting software, you can then look up the car insurance based off of the license plate. So that's an acceptable insurance information input, is to say New York license plate number and then put it in there. And then the insurance company can look up, or your billing company can look up whose insurance is for that car. I know that we've kind of beaten refusals to death. But just touching on it, the correct thing to do is always recommend transport to the patient. This always protects you. You'll never be at fault for doing that. Now, talking more realistically, again, this is me going less from an instructor and more for a this is how we actually do the job. Sometimes the hospital is not the best place for your patient. There's a lot of times that an urgent care is a lot better, or primary care. Sitting them in a hospital waiting room for 12 hours for something that could have been handled by a phone call to their primary care for antibiotics. What do you think is better for the patient overall? So it is sometimes appropriate to ask, do you want to go to the hospital? Uh, just today, I went on a call where it was a lift assist. The patient was not injured. They just tripped and fell and they needed help getting up. Yes, we should legally always strongly recommend transport to the hospital. But for this patient, I said, are you injured at all? They said no. They had no complaints. Their vitals were all good. So I said, would you like to go to the hospital? Not, all right, we should go to the hospital and wait for them to say, oh, no, you can't take me to the hospital. Be nicer. Just be like, do you want to go to the hospital? Then they can say yes or no. So that's an appropriate question to ask a lot of patients sometimes, because sometimes they don't want to go to the hospital and they just don't think that they have any other option. So, for example, if they have a sore throat and they call you and say, would you like to go to the hospital for this? Well, what do you think? And you can always say, we recommend transport to the hospital, but if you want to try urgent care or talking to your primary care first, you can try that. So, it's a touch and go thing. It's something to learn with experience. Again, you'll never go wrong by strongly recommending transport, but once again, me less being your instructor and more, um, a real life person, sometimes recommending other places to go is better for your very low acuity patients. So if there is a refusal and you do work for the fire department, one of the best things you can do for the patient is to take the refusal yourselves. In New York State, fire departments are not allowed to bill for their services. Ambulances usually do. For example, my agency charges every patient $200, more or less, for a refusal. If it's, for example, the person I went to just pick up earlier today, that's $200 to pick them up. If the fire department can go and do that themselves and the patient doesn't need transport to the hospital, that saves the patient a lot of money, and it also gives the fire department some practice in charting and doing the refusal and doing a full patient evaluation. So it is something that really helps the patients out and can help you out with your experience. It also will make the ambulance life a little bit easier. Typically in one shift, I'm going to 10 to 15 calls. The fire department might see one patient in that time. So it helps you practice your patient care. And again, practicing makes competence happen. It gives you more experience. So you should want to get as many touches to patients as possible. I know it's sometimes frustrating to do the extra paperwork, but it makes you a better EMT overall. All right, one of the most stressful things you can do, especially initially, is giving a report to a higher level of care, whether that be ALS, a nurse, or a doctor at the hospital. It can be intimidating having someone who has a lot more education, a lot more experience than you, and have them listening to you to report the patient's needs appropriately. One of the biggest things is try to keep it brief and to the point. I'll be the first to admit, paramedics and nurses have very short attention spans. You've got 5 to 10 seconds to really have their full attention to explain the patient care. So hit the high points, hit the chief complaint, the vitals, interventions that you performed. You don't need to tell the life story. You don't need to say absolutely everything about this patient because they're going to do their own assessment themselves. So just hit the high points so that they know a general idea of what's happening. Also, don't be offended if they cut your report short, especially if it's a critical patient. If it's a critical patient, I need to get to work. I need to start doing my job. I can't stand there and listen to a report for 30 seconds or a minute because I need to start doing my work on the patient to make them better. So don't be offended. Sometimes that's just required. Just like you wouldn't stand there listening to the family for 30 seconds to a minute to talk about the patient if they're not breathing. You would jump right into action, and you can try to listen as you're working, but you need to do your job. So EMS is a constantly evolving field. Now, in the time that I've been in EMS, I've gone through probably 6 or 7 full protocol changes. Uh, so keep in mind that things are going to change a lot. EMS is not what it was when I first joined, and it's not going to be the same in 2 years. So follow regional policies. They're released on the DOH website, and they're released by the agents or the region website every year. There's usually 5, 6, 7, 8 policies that are released every year, and it changes things. In New York State, the Muru app, M-U-R-U, is where you can find your most current protocols. That app might change in a year. Who knows? I've gone through like 3 or 4 different app changes. So right now, Muru is where you can find your most current protocols. And again, protocols change all the time. At the time that I'm making this, there is a protocol change that's going into effect in the state in 2 weeks. And there was one that went in effect about a year and a half ago. So protocols change all the time. It's usually for the better. It's usually because they are doing research and they are finding evidence to change these things. So they're usually positive changes, but you need to know that things will change. You have to stay up to date with the education and with all your training. So even if you don't think that you're going to do EMS professionally, when you're first starting out, you don't know that for certain. When I first got my EMT, I did not think I was going to do this for a job. I thought this was just going to be a side thing while I did another career. And here I am 12 years later, and this has been my full-time job for the majority of that time. That happens all the time. Just because you don't think this is going to be a career now doesn't mean it's not going to be a career at some point in your life. So keep that in mind when you're interacting with other EMS providers. You don't know who might be someplace else in the future, who might be a director someplace else. Just try to be positive with everyone. Treat every interaction as a mini interview, because when someone is in charge of an agency, they'll ask their providers, hey, have you heard or experienced anything with this person? And they'll get a good idea of if this is someone that we want to hire or not based off of that. So don't burn your bridges. Treat every interaction like you are auditioning for a job, even if you don't think that you're going to be doing this as a job. Big key points that we look for is stay humble, be willing to learn, have a good initiative, and just be an overall positive person. Be empathetic. All those go into making a good impression, not only in EMS, but in really the world. So keep all that in mind, especially the humble and willing to learn parts. Those are things that we really look for in this job, is someone that isn't satisfied with where they are. They always want to improve on themselves. All right, talking about recertifying. In New York State, your EMT card is valid for 3 years. Your CPR card from the HA has to be renewed every 2 years. So keep in mind, you do have 2 certifications you have to keep up, your CPR and your EMT. There's currently 2 different ways that you can recertify. There is the continuing education way and the traditional refresher way. If you're doing continuing education, first off, your agency has to be approved to do recertifications that way. So you have to ask to make sure that your agency does that. But all you do is you take eligible continuing education classes that are approved by a CIC, and you have to hit certain topics and certain time limits of those topics. So for example, you might need like 2 hours in cardiac emergencies. You might need a half hour in toxicology, so on and so forth. I believe that it's around 48 hours total that you need. A lot of that is elective, so it could be in any topic, but there are certain areas called core content areas that you have to get certain time in those spots. So that's one way to do that. That's the way that You don't really have to do a test. You also have to do a verification of skills, whether that's doing practical stations like you do in class, or proving that you have done those skills competently in the field. So that way you avoid having to take a written test ever again. So for those of you who aren't great test takers, that's a great way to recertify your card. The other way to recertify is taking a traditional refresher class. So that's where you sign up for a EMT class on the refreshing track, and you take whatever classes that you are mandated to take. You can go to every single class offered, but you can also take a challenge exam, and that challenge exam will find out that you're competent in, say, respiratory emergencies. And if you're competent in respiratory emergencies, you don't have to go to that respiratory emergencies chapter. So it's called challenging out of chapters. So you can do that as an alternate. So you can either take every class or try to challenge out of classes. The downside of that is at the end of the class, you do have to take a practical, unless if you challenge the practical as well, which you're allowed to do, and you have to take a New York State written exam. If you don't pass that exam, you aren't recertified. So that is the downside there, is you might not get certified if you can't pass the written exam. The upside is you generally get a little bit better education that way. And it's also you're completely able to do the continuing education track by taking another EMT class at the refresher level. So you can take the class and count that towards your continuing education hours, and then get certified through the continuing education track by taking an EMT class, not having taken the written exam at the end. So that's just kind of touching on how to recertify. I know it's 3 years, probably seems like a ways in advance, but that's something that you should keep in mind, especially before you come up to the 2-year mark, because it takes time to recertify. It takes time to get through all this education, and you don't want to accidentally have your card lapse because you didn't get all the education in time. So the final thought I like to leave people with is the quote that says, "I hope that if you ever need medical care, that you get someone just like you to show up." So that's either a compliment or an insult. And really take that to heart. Is the way that you practice medicine the way that you want medicine practiced on you? Do you want someone who is very empathetic and who will listen to you for a while and actually care about your needs and your wants? Do you want someone who's going to be very, very proficient in their skills? Do you want someone who is very up to date on their training and wants to do the new cutting edge things? Think about your attitude in class and your attitude towards the job and your attitude towards patients, and think, if I needed an ambulance, would I want me to show up, or would I want someone else to show up? So just keep that in mind. That's, it's almost like the golden rule. But it's really something that you should pause and think about throughout your career. As if this was my family member, if this was me, am I who I want showing up? Am I the best paramedic or best EMT that this patient could get? So that being said, I really hope that you guys have long and healthy careers. I'm always here as a resource for you, and I wish you the best.